So first, I am so happy to introduce our colleague from PCRM Edmonton, Dr. Phil Bach. He's going to be talking about diagnosis and workup of male infertility. Dr. Bach did his medical degree and specialty training in urology at the University of Alberta, and then he did fellowship in male reproductive medicine and microsurgery at Cornell in New York City. He's board certified in urology by the Royal College of Physicians and Surgeons and the American Board of Urology. Dr. Bach is an assistant professor in urology at the University of Alberta, and his main practice is based out of the Diane and Irving Kipnis Urology Center at the University of Alberta Hospital. So here's Dr. Bach to talk about diagnosis and workup of male infertility. I'm going to ask Dr. Bach to go ahead and unmute and share your screen, please.
Awesome. Thank you so much for the kind introduction. Let me just get this pulled up. There we go. And hopefully everyone can see my screen. So it's always a pleasure to be given the opportunity or asked to give this talk, and to especially with the diverse crowd that comes to the symposium. So for today, I think the hope is
Dr. Bach, sorry to interrupt. We're seeing the notes view. So if you can click on display settings on the top, the very top, you should see a swap. No, you may have to go back into slideshow. There we go.
Sorry about that.
Perfect.
So for today, essentially, I wanted to go quickly into the impact of fertility, and to kind of give us a base for our conversation today. And then in terms of the assessment, I wanted to focus more so on the semen analysis itself, because there's been a few changes over the last couple of years in terms of the direction for semen analysis. And then we'll kind of delve briefly into the medical management of male infertility, especially if you're working in an area where you're a generalist or you don't have support from a urologist, then these are all things that you can consider doing in terms of optimization or management for male infertility. So in terms of the impact of infertility, I think it's we've seen a lot of headlines over the years talking about fertility rates decreasing, and this has been something that we've seen not just in North America, but we've also seen it across Europe and across Asia as well. And whenever we see these kinds of headlines, the question always becomes, is there any evidence behind it? These are pretty alarming headlines, and interestingly enough, there is an organization that keeps a very close tab on this kind of data, and that's the World Bank, the United Nations. And so going back, a couple of generations, you can see here across the globe, we've seen a pretty significant decrease in fertility rates over time. And there are a lot of contributing factors to this, but the reproductive rate that we're kind of very worried about is, of course, two births or replacement rate. And you can see North America, Europe, developed world, we've kind of hovered at or below 2 births per family since the 70s and the 80s. Now, looking specifically at Canada, I haven't been able to find newer data on this, but it kind of reflects the global trends. So infertility, the prevalence of infertility over time has increased over the last generation or so, and is currently at around 15–16%. And this is defined as the inability to conceive a natural pregnancy after 12 months of unprotected intercourse. Now, I think when we look at causes of infertility, there is still, unfortunately, a misconception amongst the public that this is a woman's problem, female problem. But when we look at the data, you can see here that there's a male contribution or male factor contribution to anywhere from 50 to 60% of male or of infertility cases. And so when you have a couple in front of you with infertility, I do think it is imperative to investigate the male side as well. And that's what we're going to talk about today. When it comes to male fertility, the data looking at trends in male fertility, a lot of it is based around semen analysis. This is a large review initially published in 2017. It got updated not too long ago, 2023. A massive study, 288 studies looking at, I think, 57,000 men across 6 continents, 53 countries. And you can see here at the top, in terms of sperm concentration, below you see total, on the right, sorry, you see total sperm counts, on the left you see sperm concentrations. There's been a pretty significant decline over time from the 1970s to 2020. And if you look at more recent data, you just parse out from the year 2000, that decline seems to be even steeper. Now, the two charts on the lower, the lower two charts kind of show the difference between different geographic regions. And so NEA, I think that's North America, Europe, Australia, SAA, South America, Central America, Asia, and Africa. And there's a decline across the world, but definitely in the Western world, the rate of decline has been more precipitous. And so there does seem to be something going on when it comes to male fertility. Now, as you'll see when we talk about semen analysis, it's not perfect, but in terms of a surrogate marker for male fertility, there definitely seems to be a deterioration or decline over time. So I think it's now that we kind of have an idea of the impact of infertility, I think the next question is, how do we assess it? And so in terms of the assessment, it's very kind of basic principles. It's all on history, physical, and investigations. And I'm not going to belabor history and physical very much today, apart from saying that they need to be very comprehensive. And much of the information we use to diagnose or to figure out the causes of infertility should be gleaned from history and physical. When it comes to investigations, of course, the bedrock of the assessment of male infertility is the semen analysis. And when we look at a semen analysis, there's essentially three big parameters that I think are very important. The sperm count or concentration is the most important because ultimately you got to have sperm in order to conceive. Motility, I say, is probably the second most important, near a close second, because the sperm that are there got to be able to swim in order to get to the egg in order to fertilize. Lower down on that list, the third thing that we look at, the morphology, so the shape of the sperm under the microscope, head, body, tail, it's probably the least important of the three. And I think in many labs, have stopped reporting morphology. And the reason I say it's probably the least important is because the criteria for morphology is very strict. So normal morphology, we only expect 4% of sperm to look normal. The flip side of that, in a normal sample, 96% of sperm have some sort of abnormality. So whether that's 96, 97%, it's less important for me. And the fact that a morphologically abnormal sperm can still fertilize, I think the focus should really be on count/concentration and motility. Now, I bring this table up because these are kind of the reference values that have traditionally been seen. And this is the 5th edition. The WHO provides the reference values for semen analysis, and they publish a lab manual every, I think, decade or so to kind of standardize how semen analysis is interpreted. And so if you look at the important parameters here, and this is probably how you'll see it reported when you order it or when you get a report, you'll see sperm concentration almost 15 million per mil. Motility, we want 40% to be normal or to have motility, and then morphology, of course, is 4%, as we've discussed. Now, the reason I'm bringing this up is because we've recently had an update. So they published their 6th edition, and we'll get into the differences between the two. But I also think it's important to know how to interpret a semen analysis result, because there can be some confusion there. And I think there's some nuance associated. And to better understand that, then it's also it's good to know how they came up with these reference values to begin with. And so what we consider normal, those figures that we just talked about, the way that they came to those figures is that they looked at a broad collection of men, fertile men, essentially, who were able to conceive naturally with their partners in under 1 year. And so they plotted out all the semen samples for these men, and they essentially looked at the 5th percentile, and that's what became our reference standards. So the key thing to note with that is that all these men were fertile. And so whether you're above the reference value or below the reference value, all those men were fertile, were able to conceive naturally in under 1 year. And so when you're looking at the relevance of this is that when you're talking to a patient about normal or abnormal semen parameters, it's not binary. So it's not, if you're above that threshold, you're fertile. If you're below that threshold, you're infertile. I always describe it as it's a gradient. And so the analogy that I use to kind of clarify this with patients is like, it's almost like I think of it as lottery tickets. And so normal concentration, if you got 15 million sperm, that's 15 million chances that you have to conceive naturally. And with intercourse, then not all those sperm are going to make it into the uterus. Not all those sperm are going to choose the right fallopian tube. Not all those sperm are going to make it to the egg. Not all the sperm that make it to the egg are going to be able to fertilize and result in a pregnancy. And so, but if you got 15 million or more sperm, that's 15 million or more chances that one sperm is going to make it to that egg. If you've got 1 million, 2 million sperm, doesn't mean that you cannot conceive, but I think that the chances are going to be lower. If it happens naturally, it might take longer. And if it hasn't happened yet naturally, then you may warrant some assistive treatments with advanced reproductive technologies. So in terms of, I think that's an important point to understand and to chat with your patients when you get these results, is that, at the end of the day, you need one sperm to get there. But it's all about odds when it comes to the numbers. So what's changed between the previous and the new WHO editions? Essentially, they've included more samples, more men from more countries across the world. So I think the new standards are probably going to be more representative, and they are more representative of the global population. And so with the new standards, you may start seeing these norms changing in your reports. The sperm concentration is slightly different. It's gone to 16 million. Motility is up to 42%. Normal forms have stayed the same at 4%. Now, they also make a strong emphasis. They have this statement very explicit, is that just what we talked about. This is not binary. Being above the cutoff does not mean that you're infertile. It's all a gradient, and that's how these reference values should be interpreted. All right. Now, just go back. I think if you're a generalist in the community and you're in terms of semen analysis, I think it is very worthwhile to start with a semen analysis. If there's an abnormality, it's important to repeat the semen analysis. It can be done 2 to 4 weeks afterwards. Ideally, when you're giving instructions on getting a semen analysis, we often will say between 1 to 5 days of ejaculatory abstinence beforehand. Ideally, 1 to 2 days of ejaculatory abstinence, because essentially we're trying to mimic the parameters that would be seen when they're trying for natural conception, which is ideally every 1 to 2 days. Now, if there are any abnormalities, I think it's very reasonable for, in terms of investigations, to order an endocrine evaluation, because ultimately, in terms of trying to figure out what we can do or what we can change, it's trying to figure out what's abnormal in terms of the hypothalamus, pituitary and gonadal axis. And so the endocrine evaluation, I think, is reasonable. Morning serum testosterone, estrogen, FSH, LH. And then beyond that, I think that's, you can then refer on to urology or to an infertility specialist to optimize and to do the next steps in management. So what would those next steps in management look like? I think the medical management for male infertility, I think a lot of this can be advised by the generalist. And so I think I wanted to provide a brief overview of kind of what strategies we have. And if you don't have access to urology where you're working, then some of the things that you can implement or you can start for your infertile couples. So in terms of our approach, it's very systematic. And so we always start with least invasive to most invasive. And that essentially is lifestyle, and then pharmacological, and then finally surgical. And of course, for the purposes of this talk, we'll focus on lifestyle and pharmacological. So in terms of lifestyle, I think it's a lot of patients will always say, it's kind of a wishy-washy recommendation, but there is evidence behind it. And I think if you think back to the semen analysis studies that we talked about early on, the significant decline in semen parameters over time has really only been over the last kind of 1 to 2 generations. And so if we're looking at causes, it's hard to imagine that you would accrue enough genetic abnormalities over 2 generations to cause that significant decline. So the cause is definitely more likely related to environmental or lifestyle factors. And so I always have a strong emphasis on lifestyle factors, and for a couple of reasons. One, because I think there's evidence behind it, and then two, because it's modifiable. And so I think that this is a point of contact, and if you can empower that patient to kind of take to make positive lifestyle changes, it'll be good for their overall health and for their fertility, and should help them out in the long run. So when we talk about lifestyle, I think we always have to start with obesity and the impact of obesity on fertility. And as I think many are aware, obesity is a major problem in our amongst our patients. And I think the estimates have about 40% of men of reproductive age are obese in North America. And that's essentially a BMI over 30. And so there have been studies that have looked at the impact of obesity on infertility. A lot of this is population level data. But you can clearly see here that, men with obesity, again, BMI over 30, have a higher odds ratio for having infertility. And I don't have the data shown here, but the reproductive outcomes, even with advanced reproductive technologies in men who are obese, are also lower than those who are not obese. If we look specifically at semen analysis, we're going to use a different measure for obesity. BMI is starting to get replaced by waist circumference as the ideal measure for obesity. So this one's looking at male waist circumference on sperm count, morphology, and motility. And as you can see here, there are significant declines in all three important semen parameters with increasing male waist circumference. Why do we see these changes? The short answer is we don't know. These are kind of the hypothesized mechanisms. So on the left there, we think that obesity results in higher oxidative stress, which can cause DNA damage within the sperm. There's known hormonal impacts of obesity. Men with higher fat, you get higher levels of aromatization, so conversion of testosterone to estrogen. You have less testosterone overall. You have less drive from the pituitary to drive testosterone production. And then, of course, obesity has a multitude of other complications as well, in terms of cardiovascular disease, blood pressure, stress, inflammation. And so if we think of reproductive health or reproductive function as a surrogate or corollary to overall health, then if these things are not ideal, then of course, sperm production, sperm quality will also suffer, and you can get issues with fertility thereafter. So what can we do about it? Well, the approach is always we start with diet. And so the data here, we don't have a lot of cause and effect data. I get the question a lot of, what can I do, or what can I change, or what can I eat? And unfortunately, there's no magic ingredient that I have that I can advise that's going to fix infertility issues. And the recommendations based on kind of the studies or the data we have, it's essentially a heart healthy diet. And so it's not increase your fruits and vegetables. If you're having meat, then you're using less red and processed meat, fish over meat, decreasing saturated fat intake. So those are all things that are, in the Canada Food Guide, heart healthy diet. Unfortunately, there's not a sexy answer. It's not a one ingredient that's going to fix things. It's just advising about a heart healthy diet. The other side, of course, is exercise. And exercise, we have very good data in terms of the impact of exercise on fertility. And so this is one study that I'm going to highlight, a very well done randomized control trial, I think 550 men, 24 weeks of heavily monitored moderate aerobic exercise and resistance training in a group of infertile men. They broke it down into different semen analysis abnormalities, and they looked not only at semen analysis improvement, and this is rare in infertility studies, they looked also at pregnancy rates and live birth. And as you can see here, significant improvements in both pregnancies and live births across all populations. So I always tell men that, If you can incorporate moderate intensity aerobic exercise and strength resistance exercise, then it's only going to help you out. And I think it's hard to say exactly, again, which one of the two is the one that helps, but ultimately I just say if you can incorporate a nice mix, then it's going to help you overall health, and also we have strong evidence that it's going to help your fertility as well. Now, when it comes to other lifestyle factors that can be modified, the three that I focus on are here. So smoking is known to have a negative impact on sperm quality, sperm production in a dose-dependent manner. And so if they can cut out smoking altogether, then I think it's strongly recommended. Alcohol, the studies would suggest that high levels of alcohol intake have a negative impact. Low and moderate is totally fine. Low and moderate would be defined as less than 6 drinks per week. And so that's what I will recommend for men. And then in terms of recreational drugs, again, it's more associative, but the ones that have the best evidence behind them are marijuana and cocaine. And so if I ask specifically about those two drugs, and if they can stop those, then that's always ideal. So moving on to pharmacological, and I think that this is where we kind of get back to this diagram again, our understanding of the hypothalamus pituitary gonadal axis. And so we know that sperm production is strongly dependent and it has a strong dependence on intratesticular testosterone production. Now, we don't have a good way to measure intratesticular testosterone. Men typically don't like getting needles stuck in the testicles daily for monitoring. So we use serum testosterone as our surrogate. And so if the testosterone level is low, that morning serum total testosterone level is low, then we understand that intratesticular testosterone level is low, and our goal is to increase intratesticular testosterone. And so using our understanding of this axis, so hypothalamus drives the pituitary gland to produce gonadotropins, FSH and LH. LH specifically drives the Leydig cell to produce testosterone. FSH fosters spermatogenesis with the Sertoli cell. Our goal is to try to increase FSH and LH. And there's a couple of ways that we can do that. We can use SERMs, and so these medications are very common on the female side, but selective estrogen receptor modulators can decrease negative inhibition by estrogen at the hypothalamus and pituitary, which can drive more FSH-LH. We can use aromatase inhibitors, and so aromatase converts testosterone to estrogen. If you get less conversion of testosterone to estrogen, then you get less of that negative feedback as well. You get more FSH and LH drive. And then the last thing we can do is, if we're not getting pituitary production of FSH and LH, we can replace them directly. So we can use gonadotropins, HCG, and or recombinant FSH. The one thing I think is critical, and if there's one thing that, I'm hoping that you can take, if there's one thing to take away from this talk, it is that definitely avoid the use of any exogenous testosterone in the management of male infertility. So exogenous testosterone, whether that's pumps, gels, injections, has a negative impact on fertility, and it actually shuts down sperm production. So a lot of the studies looking for male birth control have looked and used exogenous testosterone. And so if there's one thing to remember, please avoid exogenous testosterone in men who are trying to conceive. So let's look into a little bit of the data. We'll run through it really quickly and for SERMs. And so this is a review that was done, a meta-analysis done in 2019, looking at the impact of SERMs on the treatment of male infertility. I apologize for the quality of the images, but you can kind of appreciate here on the left that clomiphene tamoxifen does have a positive impact, a significant improvement in sperm concentration, and on the right on sperm motility. More importantly, we don't have good data. We don't have a lot of data, but when they tried this, the studies that are available looking at pregnancy outcomes also shows that the use of SERMs can improve pregnancy rates compared to controls. What about aromatase inhibitors? The indication here for aromatase inhibitors comes from this kind of historical study, an observation that men with normal fertility had higher testosterone to estrogen ratios compared to those who had testicular failure. And so nowadays, if we will do calculation of the testosterone estrogen ratio. And if it's less than 10:1, then we will start them on aromatase inhibitors to try to increase or normalize that ratio. Where's the evidence for it? Again, this is a meta-analysis of aromatase inhibitors in male infertility. Here you can see that there's a significant improvement in sperm concentration, significant improvement in sperm motility, and also in sperm morphology with the use of aromatase inhibitors. It's important to note that those two SERMs and aromatase inhibitors, that's off-label use, but there is a long and record of their use, of their safe use in the management of male infertility. Gonadotropins are on label and they are FDA approved, mainly in the management of hypogonadotropic hypogonadism. And so most commonly we'll be using HCG with or without recombinant FSH. Pulsatile GnRH is much less commonly used. Here's the data behind it. And so this is broken down amongst multiple different etiologies for hypogonadotropic hypogonadism with HCG plus or minus FSH. On the left, you'll see here the percentage of patients that are getting sperm production back. It's about 75%. On the right, you'll see the mean sperm concentration with gonadotropin treatment. It works out to about 6 million per mil. The data for GnRH is less, or we have less data, but the results are very similar. Again, 75% of men are getting spermatogenesis back. Mean concentration about 4 million per mil. So these are treatments that do have a long record of use and of successful use in men. So I want to take a couple of minutes just to talk about a very specific population that I think we see more and more of. I see it in my practice. I'm sure many generalists are seeing it as well. And when it comes to infertility patients, I make a point to ask specifically about testosterone and anabolic steroid use. And because I think many men who are using it, it's not prescribed. And so if you don't ask or explicitly ask for it, you may not get the information that you need. And so how do we manage men who have infertility, who got no sperm, who are on exogenous testosterone? And so the first step is always going to be they need to stop their exogenous testosterone. And then the question often becomes, well, how long will it take for my sperm production to come back? And so the studies that have looked at this have looked at men who've been on birth control trials. And so typically younger men under 1 year of testosterone treatment, and their chances of getting their sperm production back, I'd say this is the data that I use when I'm counseling men. 2/3 will get it back within 6 months, 90% within 12 months, and then the rest out to 24 months. Now, there have been some more contemporary series looking to see if there were any strategies that could be used to speed up the return of sperm production. And so starting these guys on HCG and a SERM can speed up that process in these small series. So 96% of men in this series were able to get sperm production back in about 4.5 months. So what is my approach for medical optimization? So if they've got a low serum testosterone level, I will typically start with Clomid, and I use 25 milligrams every other day. And I use Clomid over HCG because it's oral, it's cheaper, it's easy to administer. If their testosterone to estrogen ratio is abnormal, I will add anastrozole as well. And then anytime I start a medication, I always check a hormone panel 1 month later, and then I make adjustments to my dosing based on those results. If they have no pituitary function, like for example, they've had surgery or ablation of their pituitary gland, or they're not responding to oral options, then I will start them on HCG. This is the dose that I usually start at. And again, I titrate my dosing based on their testosterone level after 1 month. Now, I think I'll take another couple of minutes just to talk about another topic that comes up very frequently in the office, and I get questions about it very frequently. I'm sure many generalist practices would as well. And so what about supplements? What about antioxidants? Will they help with my fertility? And so this is Cochrane level data. And you can see here that there is a very mild improvement in birth rate and clinical pregnancy when antioxidants or supplements are used. However, the caveat is that the quality of the evidence, the certainty evidence is very, very low. And in my practice, I am very wary about recommending supplements and antioxidants. And the reason is because based on the studies, and this is looking at the US and Italy, as we know, these supplements and these antioxidants are not heavily regulated by the FDA. They're not heavily regulated by Health Canada. So it's a bit of a buyer beware in terms of what you're actually getting. The studies in the States looking at over-the-counter male fertility supplements, they found the overwhelming majority of them do nothing at all because they either don't have the ingredient that's needed, or if they have it, they don't have the right amount. Similar findings in Italy. And the other thing that I worry about in these supplements is some of them will have pharmaceutical agents slipped into them. And there have been many reports, maybe not so much in the fertility world, but in the gym and muscle building world, of hormonal agents slipped in, because that's what helps guys feel better. But if you got those hormonal agents slipped in, it would have a deleterious impact on your fertility. So when patients ask me, I always tell them if they can get all the nutrients they need from a healthy diet, that's always the better way to go. So once he's fully optimized, then what I do is I repeat a semen analysis at 3 months. The reason I choose 3 months is the sperm production cycle is about 3 months. So I want a full new sperm production cycle after full optimization. And if there's an improvement in those semen parameters, then they can continue that treatment until the fertility is complete. And once they're fully optimized, we look at the semen analysis. Then, based on the numbers, then it's right back to the REI. And so based on their total motile sperm counts, they might be better to keep going for natural conception versus transitioning to IUI, IVF, or ICSI. And this is where our collaborative approach with REI comes into play. So I guess in summary, I think hopefully you'll have been able to see that, male factor infertility is a contributor to a lot of these cases. The semen analysis is central in the assessment of male infertility, but it does require nuanced interpretation. And then our medical management strategies include lifestyle modifications and medical interventions in conjunction with the REI team. So that's all I've got. I think we're on time, and so I'm happy to take questions if there are any.
All right, thank you very much, Dr. Bach. That was really an excellent review, as usual. Just a reminder to all our participants just joining, you are muted. So if you have a question, please pop it in the Q&A box. We're going to start with a question. There is a question about data and vaping for male infertility. What do we know?
Yeah, that's a good question. We don't have a lot of data yet, and that's the short answer is we don't have a lot of data yet. There are groups looking at it, and it's tough to tease out the true impact because we don't have long-term studies. The initial studies that I've seen seemed to associate vaping with better semen parameters compared to those who smoke. But it's confounded by the fact that they didn't do kind of similar quantities of nicotine in terms of the smoking and the vaping population. A lot of people who are vaping are trying to stop smoking. And so it's hard to know, is this because they're not smoking as much? I think that data is going to take some time to mature. My recommendation is, if we're trying to do everything we can from a lifestyle perspective, then that's one other thing that they can stop. But if it's vaping versus smoking, I think vaping is probably, I wouldn't say preferred, but less impactful based on the very early data that we have.
All right. And the next question is, are there studies evaluating cell phone radiation impact on male fertility, since many people carry their cell phone in their pocket?
Yeah, I don't think there's strong evidence with regards to cell phone radiation and infertility. Historically, the concern has been heat. And so cell phones in pockets, laptops on laps has been a heat issue. Do I think it has a significant impact? I don't. And I don't think there's been good evidence to suggest strong radiation impact. Again, very difficult to kind of determine cause and effect for something like this. But I haven't seen much strong evidence to suggest that it has a significant impact.
Okay, and then another question about drug use, marijuana, and male fertility. Can you expand a little bit on that and how you counsel patients and what the data says?
Yeah. So in terms of marijuana, I think that we don't have cause and effect data, and this is I think it's difficult to get cause and effect data. What we have is associations, and so they've looked at individuals or groups who were users of marijuana compared to groups who were not users of marijuana, and the marijuana users seem to have worse semen parameters and higher rates of infertility. Now, are there a lot of potential confounding factors there? Yes. So I will recommend to patients that if you can stop marijuana, then that's always ideal. Now, the question that I would get asked frequently now is this THC? Is it CBD mediated? And again, we don't know the answer to that. I think the early studies that I've seen have suggested that it's probably more THC mediated than CBD, but I don't think we don't have definitive evidence on that question, unfortunately.
Okay. Okay, thank you very much, Dr. Bach. That was excellent. It was a pleasure to have you back here.